Please note this is a pre-recorded webinar and we would like to ask that you keep your microphones muted. For those of you joining us via Microsoft Teams, you will be able to post questions and comments in the chat, although we recommend that you give the webinar your full attention. Presenters will endeavour to respond to any questions posed, and all questions will be answered and slides circulated after the webinar. Thank you.
So, welcome everyone. Welcome to the Infection Prevention and Control webinar for care homes in Greater Manchester. My name is Moona Abdelaziz and I'm the Director of Public Health for Salford City Council. I work closely with the Directors of Public Health in the other 9 areas of Greater Manchester, and we also work with colleagues across the North West. Our public health teams work together and we have an infection prevention and control cell looking particularly at care homes, which comes together across Greater Manchester Health and Social Care Partnership, Public Health England, the local public health teams, and we work with the Health Protection Confederation, which also considers that work alongside the care home managers. In my role, I oversee the response to COVID-19 in Salford, and on behalf of colleagues in the other areas, we are working to ensure that care homes and other care settings are COVID secure. As in today's webinar, we are sharing good practice and preparations for the second wave in our care homes, as sadly, the first wave did affect care homes the most. And we know that we are heading into winter where other viruses will continue to circulate. Before COVID, previously, I was the Director of Public Health for Warrington, and I actually started in Salford in January. Then straight away, we were in COVID. And our outbreaks in Salford started very early in care homes in this pandemic. Today, for the webinar, we have brought together a group of great speakers from Public Health England, Greater Manchester Health and Social Care, our local authorities' public health teams, infection control, and it is great that we have the contribution of care home managers to be presented today. The webinar was pre-recorded in the beginning of September, and so we will run the video to the end. We will have the presentations running at one after each other. Then this will be followed by a question and answer session with all of the speakers. During the video, we welcome you as the audience and we ask that you listen to the presentations, and if you could keep your mics on mute, but do post any questions within the chat function. We'll be looking at the questions as you're putting them in, and our speakers and our panelists can respond to these at the end of the videos. Today's webinar is the result of joint working between the Directors of Public Health and the Directors of Adult Social Care, as we have been supporting the care homes through these unprecedented times. On the webinar today, we have Mark Fitton, who's the Director of Adult Social Services in Stockport, and he's joining us on behalf of the colleague DASIs in the other areas. So for now, we'll start the video, and we hope that we get to hear some interaction from you, mostly in the chat function, please, and I'll hand over to start the video now. Thank you.
Good morning. My name is Dr. Matt Peggery. I work for Public Health England in the Northwest team. My role previous to the COVID pandemic was pretty similar to what it is now, to be honest, but with a different shift in focus. So I'm part of a small team based in Greater Manchester that works together with other partners, such as colleagues like Moona, Directors of Public Health, and Sarah, Community Infection Control teams. Together, we work to prepare for and aim to prevent and then respond when they happen to cases, clusters, or outbreaks of infectious diseases, and indeed other health protection risks such as environmental risks and chemical risks. So naturally, the focus of my work has shifted from those infections to the COVID work, and although we worked hard before, I think we're working even harder now, but it's the same approach we take with our partners. Today, I'm going to be covering the test and trace program for COVID in the care home context and setting. And I'm going to cover three main themes. First, the basics around cases, contacts. This will include a few definitions, and outbreaks, when to suspect an outbreak and what to do with them. Secondly, the testing aspects, how it works in care homes. And finally, test and trace program with a focus on the tracing element, i.e. the contact tracing. Some slides I will gloss over fairly rapidly because the themes will be covered in later sections of the broadcast. Starting with the basics, what do we mean by cases? So all of you will probably be well aware of the symptoms of COVID, the three key symptoms to look out for. And when we talk about cases, we often categorize into confirmed cases, i.e. with a positive test, or a probable cases, clinically suspected cases with the right symptoms. The only comment I'll make here is with regards to care homes, the older population can sometimes present with atypical different types of symptoms. So we do need to have a fairly low threshold of suspicion for these, and these are highlighted on the right box here. Defining cases in residents and staff and defining their infectious period. So cases, like I said, have got the symptoms, and they are those that pose the risk of passing the infection on to others during a certain period, and that is called the infectious period. And that infectious period is different in the elderly compared to the general population. So for residents who tend to be a bit more vulnerable and elderly, we define it as 48 hours prior to the onset of symptoms, up to 14 days after the onset of symptoms. If there are no symptoms, we use the date the test was taken on as the benchmark, as a starting point. For staff, the infectious period is different. It's the same as the general population. So that starts again from 48 hours prior to the onset of symptoms, or the test date if they didn't have symptoms, until 10 days, not 14, after that date. So the reason we recommend exclusion for cases is obviously to prevent the risk of them passing it on to others. So the exclusion or isolation period reflects the infectious period. So for resident cases, 14 days from the onset of symptoms, and we also advise they remain fever-free, for 48 hours before stopping the isolation. If other symptoms linger, that's usually fine because they don't necessarily mean they're still infectious. Similarly for the staff cases, the exclusion mirrors the infectious period, i.e. 10 days after the onset of symptoms or the test date, and again, free from fever for 48 hours before returning to work. Contacts are a different group of people. So essentially, when a case is in their infectious period, if they come into close contact with another person, that other person is exposed to them during that infectious period and therefore is at risk of developing the infection themselves. These are called contacts. And these contacts may or may not at some point become a case themselves. And that period during which they may become a case, or from the time to the exposure to the infectious case until they develop symptoms or test positive, is referred to as the incubation period. And for COVID-19, that incubation period is 14 days. So the reason we isolate contacts is not because they are infectious and will risk infecting someone, but because at one point they may become infectious. So it's a precautionary approach there. And that, again, it's all based on the incubation period rather than the infectious period. So contacts should be isolated for 14 days, whether they are residents or staff. When to suspect a case or an outbreak, it's all about the case definitions discussed in the previous slide. For an outbreak, it's pretty simple. 2 or more cases within 14 days that either meet the clinical definitions or probable case or are confirmed, either in residents or staff. Any of this constitutes an outbreak and needs investigation and risk assessment. Moving on to contacts, I've explained the general principle of a contact. It's all about what we do with contacts is all about the level of exposure, which I'll come to into a minute. But in terms of pragmatic definitions for this context, we talk about resident contacts are those living in the same floor, a unit, a bit like household contacts in the community, or those that have had 1 meter face-to-face contact for any time. Those that have had any contact within 1 meter for 1 minute or longer, and those that have spent more than 15 minutes within 2 meters of an infectious case. Obviously, we're talking here about exposures to an infectious case. For staff contacts, it all hinges on how well they were protected during their exposure to that infectious case. If they wore the right PPE and wore it correctly, they should not be considered a contact. If they haven't, then the definitions mirror those that you can see on the left for the resident contacts, with the two additions. One is the environmental risk posed by cleaning an area potentially contaminated by a case. Obviously, we're talking about the first clean here. And the other is, as for any member of the general public, if they get a notification from the national test and trace system that they are a contact, that would also constitute a contact. Now, I'd like to draw particular attention to this slide. COVID-19 doesn't stop within the care home. And there is a well-recognized human psychological phenomenon whereby, as professionals, we may tend to be a bit more vigilant and more cautious in our working environment and practice, particularly in caring sectors, and maybe let our guard down in more social, relaxed kind of environments outside of work. So important to remember that there are infectious cases of COVID in the community, and particularly in Greater Manchester at the moment, as I'm sure you're aware from the news and your personal experience. So important to remember that outside in the community, one may become a contact of a confirmed case. And the definitions for those type of contact are fairly simple. Household contact is the principal one, and secondly, what we call close contacts, and that's regardless of face coverings, etc., because we're talking about the community here, not a caring environment, a clinical environment with proper PP. So again, very similar to the previous, face-to-face contact for any length of time within 1 meter. More than 15 minutes within 2 meters, and also common sense things like traveling in a car, a small vehicle, and again being notified by the test and trace system. So this hopefully really brings home that we need to remember social distancing, not only in the caring clinical social care environment, but also outside socializing, car sharing, maybe in kind of communal staff areas, etc., where it's easy to forget and let your guard down. So what actions do we take or recommend for contacts in the care home? The first step is obviously identifying the contacts, who meets that definition for a contact, who's had contact in the infectious period of the case or cases, giving the right advice, which is self-isolation for cases and exclusion for staff. And for residents, ideally, isolation should be in a single room, if not possible, cohort, and that will be discussed in a minute. For all of this, support is available from your local community infection control team and your local health protection team in Public Health England. For community contacts, the National Track and Trace Service will advise household contacts and close contacts to self-isolate for 14 days. Just a note here, for any of these contacts isolating during the 14 days, even if during those 14 days this contact gets a negative result, they still need to complete the 14 days because they are still in that incubation period, that phase, where they could still potentially develop symptoms and become an infectious case at a later date, anytime after that negative test, up to those 14 days. I'm going to let people read this slide because it will be presented later on in the webinar, and if you want to dwell on it, you can pause. Same for this slide on residents who walk with a purpose, particularly relevant to dementia units. And finally, a quick summary of key actions to take during COVID outbreaks. I won't read them all out, but 2 key points. Support is always available from your local community infection control team or Public Health England health protection team. And there are really good resources out there, national and local, including a bespoke GM care home pack, which I will refer to at the end of the presentation. On to testing. You may have heard of the 5 pillars of testing outlined in the government's national strategy. Those most relevant to care home testing are pillar 1 and 2. Pillar 1 relates to any type of testing where the testing ends up being analysed in an NHS or Public Health England laboratory. So usually more of a local system within the Northwest or Greater Manchester. Pillar 2 is very different and a much broader set of testing activity, which is led and kind of coordinated, shall we say, by the Department of Health and Social Care, and refers to any testing that ends up being analysed in a network of very big private laboratories, so not NHS or PHE. So they are quite separate systems, but a combination of both of each can be used for different situations. I'll go on to testing in the care home setting. Testing in care homes is far from simple. It's quite complicated. I'm going to break it down into two basic scenarios. The routine testing when there is no outbreak suspected or ongoing, and then the type of testing when there is a suspected outbreak. Starting with the former, there's an ongoing program that is being rolled out. It's not fully complete yet, where essentially Department of Health, via Pillar 2 testing, want all care homes in the country to be regularly tested. It's being phased in, starting with care homes catering for the elderly, and then we'll move on to all other care homes after that. Word of caution, as you may be aware, there was a bit of a hiccup with one of the testing kits having to be recalled recently. That was a Rundux kit, but that is pretty much sorted now with those having been replaced. A bit more detail in this program. The concept, as I was saying, is to test all staff and residents every 28 days. And I really mean all staff. We're talking regular staff, bank agency staff, cleaning staff, cooking staff, any auxiliary staff, etc., etc. It's quite easy to register online. You'll get a kit, relevant amount of kits sent out, and the schedule is outlined here. So the first week is all staff and residents. Then the following 3 weeks, staff, only staff. Then we start the cycle again with staff and residents, etc. There is a helpline available, 119, and sorry to state the obvious, but if at any point during this testing an outbreak is detected, i.e. 2 or more cases, we then move on to the outbreak testing schedule, which I will cover now. So this is a schedule for in a situation where there is a suspected outbreak, and this type of testing has 3 main rounds, with the 2 first ones being managed and delivered by Public Health England, so via the Pillar 1 testing pathway. Just an aside, for single cases, probably important to know, these can be tested at any time outside of these schedules, and local systems are in place. So again, just give your community infection control team a call and they'll advise on the local system for this. Once there is a positive in a single case, the key question is, how likely is this to represent the beginning of an outbreak, i.e. will there be further cases? And if it is quite likely, we may decide to activate the outbreak testing pathway. So onto this pathway, the first round is testing for all residents and staff, asymptomatic obviously, because the symptomatic staff shouldn't be in the care home. And it's a whole home, so all units, not just the floor or the affected unit. Round 2 is a bit of a kind of mop-up or quality assurance exercise, shall we say, whereby anyone who's missed testing in round 1, anyone who's had a kind of dodgy result, inconclusive or invalid in round 1, and anyone who's had a negative result. And the reason for that is to reduce the risk of false negatives. Now, it probably makes sense that round 2 may not always be needed, because if you get really good uptake in round 1 and everyone's negative, round 2 may be cancelled. You don't need that kind of mop-up or quality assurance. The last round will be day 28. But before I go on to that, in between, the background routine testing from the Department of Health I was referring to previously can still continue. So week 2, day 14, and week 3 and day 21, that system via Pillar 1 can continue for the staff. Day 28, another 4 round of testing, again done via the Pillar 2 route. It kind of aligns with that routine testing, but it's very handy because if everyone tests negative at that 3rd round of screening for the outbreak, we can be reassured that we can declare the outbreak over. Symptomatic residents that are detected after round 2, again, as we're saying, if they're detected, usual recommendations for those, both for staff and for residents. And if you get more than 2, obviously it constitutes an outbreak, and the whole cycle of outbreak testing continues once again. As explained, we usually use 28 days to declare an outbreak over. 28 days is 2 incubation periods, 14 plus 14. And 2 incubation periods is the standard benchmark we use to declare outbreaks of any infection over. This is a little potentially complex kind of algorithm, flowchart, shall we say, which outlines the roles of care homes, community infection control teams, Public Health England health protection teams, and laboratories. This is all included in local resources, so I won't go into too much detail. A key message and plea we have from our laboratory colleagues is care homes are discouraged from calling laboratory directly. The labs are not set up to give results out directly to care homes. The communication between care home and labs needs to be via community infection control teams or indeed Public Health England. On to the test and trace programme. The contact tracing model in England is a 3-tiered model. There is a large cohort group of call handlers that work in what we call the level 3, and their role is to provide telephone advice to the contacts of confirmed cases. Level 2 is a smaller group, and they are dedicated more kind of healthcare background staff with more kind of proper contact tracing, shall we say. Their role is to get in touch with confirmed cases that have not completed the online option for filling in their questionnaire on COVID. So either because they've decided not to do it or they've failed to do it in 24 hours, they will then get called by level 2. And level 2 staff will sometimes escalate certain complex cases to level 1 staff. By complex cases, I mean usually cases that are somehow associated with a higher risk setting. For example, a member of staff working in a care home or in a hospital, or indeed an inpatient in a hospital or a resident in a care home, or a school teacher or university teacher, or someone that has visited an outpatient appointment or a GP's. They go to level 1, and level 1s all over the country is essentially a network of local multi-agency partners that have their own system to follow up these cases. So they follow up the actual cases, but their contacts outside of whatever setting we're talking about, so to use the care home example, if it's a staff member, level 1 will work with a care home via the infection control team to identify all the contacts in the care home, but the contacts of the staff member outside of the care home, they will go back to level 3 for that national phone call and advice. That is the current model. I'm quickly going to talk through the pathway for the contact tracing. It all starts when someone has a positive test, which then gets fed in to the national test and trace result, which then generates an automatic message, usually by text message, to tell the case, you are positive. This is the initial isolation advice you need to do, and please complete this online questionnaire. Where the case uses online questionnaire, they input all the information, including details on their contacts. Then their contacts get the option to do the web tool as well, and will get information that way. If they don't or fail to do it, if the cases don't and fail to do it, they enter level 2, who does the questionnaire with them over the phone, and then passes all their contact information to level 3, who will then phone their contacts. As I said, complex cases go to escalated to level 1, and level 1 works locally with their systems, which I'll go on to in a minute for GM, to manage that particular case. So this is the penultimate slide. Just to explain the GM picture, we have what we call a integrated contact tracing hub, which deals with all the level 1 referrals, and that is a multi-agency group with Public Health England and Greater Manchester Health and Social Care Partnership, local authority representatives, fire and police, and voluntary sector, and I'm sure I'm missing some. And the basic model is all referrals come into that hub, and they then get farmed out as relevant. So in areas or for cases linked to context where there is a kind of public support system around there. Example, a care home will have dedicated support from community infection control teams. Another example may be a police staff member will have support from their occupational health. Same with hospitals, etc., etc. So where those exist, we send the referral to what's called a central point of contact, and for care homes that will be the community infection control team. Where that kind of network doesn't exist, for example, a case in a workplace or a big warehouse workplace or a restaurant, whatever, then the hub will manage those cases. Just a few final points on the bigger picture is the whole contact tracing landscape is rapidly evolving, with some local plans to try and take on some what we call locally supported tracing. This aims to shorten the time period whereby cases are contacted. So when cases end up in level 2, instead of waiting maybe 48 hours before they get failed to contact, within 24 hours, if they haven't contacted them, they come straight to the hub, and we've chased them up locally. And we're looking at similar approaches for cases of those particular contacts as well, though this is only a pilot. Bigger system-wide, in terms of future direction, there seems to be a move for locally delivered and owned end-to-end test and tracing programs for all cases, all contacts, etc. But a lot of challenges involved in that, and they really need to be ironed out still. So that's in the future. Finally, this is a screenshot of the resource pack I was referring to. All your community infection control teams have a template which they have adapted and have sent to your management teams for support. That's the end of my presentation. I look forward to catching up with all of you on the Q&A session later. Goodbye.
Hello, my name's Karen Davis. I'm a home manager in Manchester. I run an 87-bedded care home with care over 3 floors. 70% of our residents are living with dementia. So we have a real understanding of how to manage people living with dementia and all things COVID in a care home. I'm going to talk today about whole home testing and hopefully give you some top tips about how to manage that, what can be quite a scary prospect. So for the people that have already embarked on whole home testing, you'll understand what I'm talking about. It does feel like it's a mammoth task. It feels like it's taking huge amounts of resources away from what you consider to be your normal role as a care home manager, away from your nurses doing what they're paid to do and delivering care to your residents, and from your care staff. It can have impacts on bringing staff into homes on holidays, and on days off in order to facilitate your testing programme. It is mammoth. I won't make any excuses about that, but there are ways of managing that within your resources in a much less stressful way. We started off by having 2 staff testing everybody over 2 days. We managed to get to the point where we could test 110 staff and 87 residents over a 2-day period, and that was tough. And it did have massive resource issues just in the testing programme alone. That was without registering those tests on the appropriate websites. We've moved away from that slowly, and we are now in the position that we've got staff trained and educated and confident, and they are testing themselves. So we've moved away from 2 people, lots of resources, to a position where we've got staff that are very confident and able to test themselves. And I can talk you through that programme. What we have done is we arrange a courier, and you can do that on the website. That's quite easy if you're registered with the Department of Health NHS website for your testing programme. For residents testing, you can test at weekend, and I know that there's been some requests for managers to arrange testing at weekend. If you're not there yet with your staff team, then at least you can arrange for testing residents over the weekend, because you don't need to register those tests until the Monday. It's not essential that the tests are registered on the same day that the test was done. What is essential is that the tests are done and they're collected on the appropriate day by the courier. That's the crucial thing. 24 hours after that, you can register the test, and there's no harm caused. That's not a problem. We've been doing that for a good 5 months now, and we haven't had an issue with that. So you can arrange a courier. You can then must remember to gain consent from your resident group for testing, and if that person lacks capacity, have that conversation with their next of kin or power of attorney or social worker. Make sure that you've gained that consent. You might have to have some supportive conversations with relatives about what does that look like. What are you going to do if that resident tests positive? What's the care going to look like? What are the implications for them? So it means you being aware of your strategic plan should a resident become positive, and have confidence to be able to discuss that with their loved ones, so to put their fear, allay their fears and put their minds at rest, because it's as scary for them being once removed from this situation, and you have to be prepared to have that honest conversation with them when you potentially get somebody testing positive resident-wise. So again, you consent, you evidence that. What my next advice would be is to create a log that you pre-populate with as much information as necessary. So it's going to be the resident's name, their date of birth, their NHS number. We suggest that you use the home's email address for the return email contact, and if possible you use the home manager or the home mobile on-call phone if you've got one. If not, they're very cheap. You can go and buy one for about £10. and use that mobile number for the text alert coming back into the home. So you get 2 alerts, one via email and one via mobile for your results. So pre-populate your log. That's really, really important. If you do the preparation work before you start testing, it will reduce your stress and anxiety, and it will streamline your service. So populate your log. There are lots of training online. The Department of Health have got training online around populating group registrations now. So we've moved away from individual registrations of residents or staff, and you can now do group registrations, and there are new training programs available in webinars from the government site, so you can familiarise yourself with that before you embark on that group process. The testing remains the same, the registration's just slightly different, but it is actually easier to manage as a consequence, and it takes a lot less time and resources to be able to do that. It's really important that you get both of those opportunities to get an alert, because you're not always guaranteed getting a text alert, and you're not always guaranteed getting your email alert. So spread your net wide, make sure that you've got 2 alert opportunities so you can act quickly on a potential positive or an inconclusive test result. Then you can register those tests on the Monday. People living with dementia don't always take kindly to what can be considered quite an intrusive test. There are ways around that. You can demonstrate. What you can do is use a test kit as a demonstration kit, so you can talk the resident through what's going to happen and gain their consent that way. There are better times in the day to test than not. So maybe when people are more receptive, when they're having their teeth cleaned, when they're eating and drinking, and they're in their best frame of mind, they woke up early. So capture that moment when it's a positive experience for residents. There is a possibility that you can have a member of staff being tested, and they can see that process is undertaken and it's not as scary and as obtrusive as they may think. So do a testing program so that you're testing a member of staff, and then you test a resident, so they've seen that process and they understand, maybe non-verbally, but are able to understand what's going to happen next. In my experience, we haven't had anybody yet that's been clearly refusing to have a test done, because we've taught them through them, supported it, evidenced it, demonstrated these things, just to demystify a lot of it. But if you are in a position that you're not able to test somebody, then you must seek advice from your mental health team. It's really important that you don't deal with this as an individual home, but you actually use your partners, use the professionals that can support your placement, and talk to the professionals that can help you in your obligation to do whole home testing. You're not on your own. You've got lots of partners out there that are there to help and support you through that program. So yeah, enter your communication log on registration, and then make sure that you use your UN number, which is your unique number registration. Keep that record of the date, the time that you did the test, and use that as an opportunity to chase your results if they don't come through. Generally they come through within 48 hours, maybe a day after that, but after 3 days, if you haven't had a test result, I would suggest that you chase that result through your public health or your NHS online or telephone number. But you must have that unique number, because you're gonna start overlapping, particularly with staff testing. You'll overlap with test results because you're going into your following week's testing and you haven't got your result from the week previous. You could potentially have somebody carrying a virus positive case in-house and still working because you haven't been able to obtain that test result. So it's really important that you use your partners to get those results into the home as quickly as possible. It's pretty much the same with the staff testing, but as I said, we've moved on a little bit from doing two staff and doing with staff, because we employ people with huge amount of skill and are able to self-test. So once we've got the people's confidence levels up, we should be able to trust staff to be able to test effectively themselves. We trust them to look after our most vulnerable people. They have got transferable skill sets and they should be able to test themselves. Those people that are not confident or need some support, absolutely be there for them. But take yourself out of the equation if you don't need to do that, because you're using resources unnecessarily. So what we've been doing in whole home testing is, again, arrange the courier in advance, because you need a courier to collect your tests, so never forget your courier arrangement. Pre-populate the log again. It's really important that you do that. In the new registration process, you fill in a spreadsheet that you save, and then you submit the spreadsheet. The lovely thing about this log is now that then self-populates your registration program, and you only have to really pretty much put the unique number in, because the rest, the IT does the rest of that for you.
Yeah.
On testing day, again, preparation is absolutely crucial. If you get the Kingfisher tests, which are a box with a plastic bag in, with a test kit and a tube, and a swab, and a little cushion to wrap your test tube kit in, prepare for that. So make all the test kit boxes up first, so you know you have your unique number on your sticker, you have a unique number on your box, and you've got a unique number on your test vial. Make all those boxes up so your prep work's already done. Have space for staff to enter the home if possible, so that they don't have to enter the resident building. So you've got staff coming in on shift, so you start your program as early as possible in the morning. Staff come in. My staff don't come in uniform. They're expected to come in their street clothes, and then we expect them to get hand washing and get changed into clean uniforms for each shift. So we facilitate that, and we've got that process in place in front of house, so staff can also come in on shift and they do their testing program at the same time. So they come into work, they get the hand washing, they get changed, and they do their own test. So we've got hand washing facilities, mirrors, they can do their own test kit. There's a member of staff there to support them if they need that. There's somebody there also to check to make sure that they follow the procedure. They've put their name on their unique sticker, which we keep as a reference document. They've populated the rest of the log with the time and the date that the test was done, and they've put the unique number next to their mobile number, date of birth, and name on the log. So that's the record of the date, the time, who had the test done, what their unique number is, and that matches the box with the document and the document and the test kit, all matched up, sealed, and then in the box that goes to the courier. It is that simple. It takes some time to get to that point. But once you've got a competent staff team and you've done your preparation work, it's probably less than 2 minutes for each member of staff. And then we also have staff coming in over a 2-day period, either Monday, Tuesday, or Tuesday, Wednesday. We let them know via Facebook. It's a regular program of 2-day testing. People that are on leave come in on the day for the testing for when they're coming back into work the week after. People that are on days off come in. We're happy to pay for them for the period of time that they're travelling, if that's needed. Generally, people are grateful that they're getting a test and that they can guarantee that they're safe and that they haven't got the virus. So we get people to come in. They write their name and time and unique number on the log. Again, it's really important that we have 2 alerts. So the staff member mobile is the mobile number that we use so that the staff member gets the alert for their results, and we use the home email address. So again, we get an alert. So we've got that double up of possibilities of alert, because sometimes the staff member won't get the text alert, sometimes the home doesn't get the email alert. You're not always guaranteed to get both. So at least you're going to spread your net again to make sure you get an alert at some point. We haven't had staff really refusing to do that. I think that we've been really inclusive. We've tried to educate staff about the importance of testing and the importance of speedy responses for testing. We've supported staff through that process. And I think actually staff are quite pleased that they're trusted to be able to do their own test, because we're not doing to them, we're doing with them. They are part of the process. They are involved in the whole process of testing, for whole home testing. And we do have staff that will coach each other, because it isn't a particularly nice test sometimes. So you can have another member of staff coaching another member of staff about whether they're hitting their tonsils or not. So it is very inclusive and very supportive. And I think that's a better way of getting people involved and feeling included in the programme, rather than being done to. We do also ask staff to make sure that they wash their hands before and after the test, and that they definitely blow their nose before they do the test. So that's really been how we've moved away from using lots of resources to cutting time down to probably about 2-3 minutes per staff test. And we are now moving towards doing weekend testing for staff as well, because I'm confident that the team have been able to develop those skills, understand the process, understand the importance of completing the log properly, and then that gives us time then to register those tests. Some homes may be obliged to let public health know who's been tested and what their results are. I would ask you to talk to your public health team, because what you don't want to be doing is duplicating information. So if you're obliged to use the log through the system, public health are going to be notified if you get a positive result anyway. They don't really need to know who's been tested and when, other than that a job's been done. Also, some homes, especially large corporates, you'll be expected to do an internal log of evidence and who's been tested and what the results are. So if you're having to do that as well, that is potentially going to take up more and more resources. So the time taken to do the testing, if you can get that down and develop a slick system that suits your environment, that suits your staff team and your resident group, it's going to be less of an odious task and a more inclusive task. So thank you.
I'm Ben. I'm a public health registrar and I currently work for Stockport Council. At the moment, my responsibilities are looking after the test system for COVID-19 within Stockport. But before that, I've been a public health registrar working in various different places within Greater Manchester. So I've worked for Salford, for Trafford, for Public Health England in a few different roles within the Greater Manchester and North West teams, and now in Stockport, doing kind of quite a wide variety of different functions. Anyway, so I'm here today to talk about testing for COVID-19 within care homes and hopefully fill in a few little bits of information around the other presentations that have been made today as well. So I think you're probably already aware there are two different types of tests for COVID-19 that do two different things. The main test that we talk about and we'll discuss today in this presentation is the antigen tests. They're the swabs, the mouth and nose swabs that show if you've recently or very recently had COVID-19. You'll also have come across, at least in the media, discussion of antibody tests. They're completely different. They're to show if you've previously had COVID-19. They can't show if you've currently got it, but do show whether you've previously had it and generated a resistance to it. And antibody tests are normally blood tests of one form or another. We won't go into antibody tests in much detail on this call because they're not as useful as antigen tests for managing cases and outbreaks in care homes. But you will probably hear more of those in the coming weeks as the government rolls out a programme of antibody testing for care home staff. So there are four main reasons why we use antigen tests. We use them for clinical management because they help inform the medical teams within a hospital about how to look after somebody if their situation deteriorates and they need to be admitted. We use them for infection control purposes, and that's the main reason for using them within care homes, because they inform what we do to isolate people, to do barrier nursing, and help us to understand when we can lift those measures. We use them to manage outbreaks, and particularly those tests are useful when we've got multiple cases within a care home, because they help us to understand what sort of situation, what sort of issues we're looking at, and whether everybody has the same infection or whether there are different infections circulating. But we also use them outside of the care home to enable contact tracing, so particularly for members of staff, so that we can look at their family, any social contacts they have, anywhere else they might work, and understand who else they've been in contact with, and seek to protect those people and keep them as safe as we can. So we test through 3 different programs within care homes. There's one route for testing, and the exact way you access these differs slightly by local authority, so I won't go into the precise access routes. But there's one way of getting tests if people develop symptoms. We then offer further testing for outbreaks at the start of an outbreak if we suspect an outbreak initially. We then offer further testing 5 to 7 days later, and then 28 days later. The most important of all of those tests is the first one, the one for somebody who develops symptoms, because somebody who develops symptoms has a substantial chance of having COVID-19, and the sooner we identify it in the first case, the easier it is for us to manage it. But the outbreak tests are also really useful. So as soon as an outbreak is suspected, PHE can organise with local authorities for a full round of testing of everybody within the care home. That then is repeated about a week later, and that is repeated just for those who've tested negative or had a void test. It's also repeated 28 days later to determine whether the outbreak is over or not. And then finally, but the one that creates the most work, we offer regular testing. That's through the government's testing portal in most areas, which is weekly for staff and every 28 days for residents. And all of those are antigen swab tests and are kind of working in the same way, interpreted in the same way, even if they're managed slightly differently. So to continue, I just wanted to explain a little bit about how the tests work. So antigen tests simply detect whether there are virus particles in somebody's nose or throat, and it's looking for the genetic material that makes up that virus. The tests are really highly specific. It's very, very rare for a test to come back as positive for somebody who doesn't have those virus particles. But because those virus particles or the debris from those viruses hangs around in the back of the throat for a while, people can test positive for about 6 weeks after they were infected, despite the fact that they wouldn't be infectious after about 2 weeks in most cases. So while the tests are highly specific, you can get a positive result quite a long time after the point at which you really wanted to detect it, and that has consequences for how we interpret the tests. The other thing to note is the tests aren't very sensitive. They miss a lot of true positive cases. We think about 30% of people who have the virus will still get a negative test result. So people who have that negative result might still have the virus. And if somebody has symptoms in a care home setting, they need to self-isolate regardless of that negative test result. And particularly when it comes to staff, if staff test negative, then it's for the care home to determine whether they can manage to keep that member of staff outside of the workplace for their isolation period that would have applied, if they can manage without having that member of staff back in. But that's a difficult issue, and it's for you to manage. So in terms of what does that mean for interpreting the results and what we do with the results, so positive tests, particularly in residents, confirm the need for self-isolation and to maintain barrier nursing measures for 10 days for the case and for 14 days for the contacts. There's lots of detail available about how the contact tracing takes place, and I know Matt's already discussed that as part of this webinar. Negative tests in care homes don't allow residents to be released from measures, and that's because they aren't reliable enough. So we think, as I say, about 30% of those tests might not be correct, and that's why it would be too dangerous, too risky to release residents from self-isolation even when they test negative. So the requirement to maintain that isolation from 10 days from symptom onset for the case and for 14 days from symptom onset for the contacts remains important. When we have repeated test results, the interpretation gets a little bit more complicated, but there are a few rules of thumb, a few things to understand about how the tests work, which really help here. So a positive test result always overrides a negative result. So if you test somebody through different routes, through different channels, or through the same channel, with lots of tests close together, then the one that you have to believe is the positive results, because positive results are just so much more reliable than negative results. And that applies even if you have several negative swabs. But after a positive result has been given for somebody, there's no point retesting them for a 6-week period, because they will still be antigen positive for that 6-week period. So getting that positive result doesn't mean that there's a new infection necessarily. Getting a further negative result would suggest that the test may be wrong, but after 14 days, the isolation period for most residents would have ended. Now, longer isolation periods are recommended for some residents who are immunocompromised, but you need to check with Public Health England for sort of precise details on that, or with your local infection prevention and control team if they are happy to answer those sorts of questions. One of the other areas in which testing takes place connected to care homes is around admission to care homes. And it's really important that everybody who's admitted to a care home should be tested either before or after admission. If patients are being admitted from hospitals, the test should be before the admission takes place. And you'd want to see a negative swab for somebody being admitted from a hospital, or you'd want to be confident that their first positive swab was long enough ago that you can be confident that the person is no longer infectious. If people are being admitted from the community to a care home, then that's a little bit more complicated. And I know that different care home groups and different local authorities have taken slightly different views on this. But the important thing is to take advice from all those people who have it to offer, including local authorities and PHE, and apply some judgment to it. Whatever your policy is on this, you need to be aware of the turnaround times for testing. So at the moment, it's impractical to have a policy that people need a negative test 24 hours before admission, because most test results are taking about 48 hours and sometimes longer to come back. So the policy needs to reflect the abilities of the testing system to deliver the results that you'd like to see. But also consideration needs to be given to really urgent admissions, the admissions of people who can't safely be looked after in the community because their condition has deteriorated. And then finally, while admissions tests are absolutely worth doing, you still need to look at them with some skepticism. If you get a negative test result, it could be wrong. And that's why our advice is always to isolate and barrier nurse new residents for 14 days after their admission, regardless of what results you've had for them. Before I finish today, I just wanted to go through a few of the sort of common issues that have been escalated to me and that I've been aware of in Stockport, and just let you know, for the ones that we can do something about, what we've been recommending. Some of these issues are system issues. We know that the testing system at the time of doing this presentation on the 15th of September is under an incredible amount of strain and is really slow at the moment. So the main issue that's escalated at the moment is that test turnaround times are slow, particularly when the system's under pressure. One of the recommendations to try and get a quicker response from the testing system is to test at weekends. We know in some homes staffing makes that incredibly difficult to do, but if you can test at weekends to even out the demand that the testing system and the labs face across the week, that's really helpful and really appreciated and can lead to faster results. We know that some homes have had tests returned as void, and that normally happens when the little vial, which is normally the clear tube with a red cap, isn't sealed properly. So it's really important to ensure that that cap is tightly screwed shut. There are lots of other reasons why void tests, why tests sometimes give a void result. Sometimes that might be because the time from testing to analysis is too long. It can also happen if a home takes the test too long before the courier collects it. So it's really important for the whole home testing to book the courier before you take the tests, as is detailed in the guidance. Outside the fridge, it is possible for the sample to degrade to the point that it's no longer valid. And you need to reorder regular tests. So for the whole home testing system, I would have always assumed that when setting this up, it would automatically repeat on a 28-day cycle, but it doesn't. So 1 days after your first bulk delivery, you need to order again through the care homes portal on the gov.uk website. And it can be helpful to set a reminder so that you don't forget that. Just a few more of the common issues. Repeat positives. We'd already mentioned that after someone tests positive, it's best not to retest them for 6 weeks. That wastes tests and adds extra pressure onto the system because the results are not informative for us. And one of the issues that we've had in Stockport is that when people have, against advice, repeatedly tested staff, we then have to contact those staff to do repeats of the contact tracing that we've already done, which causes lots of disruption and confusion for the staff, both in their social lives and at work. And we really would like not to have repeat tests that risk causing test and trace to do that work repeatedly. And then finally, we know that asymptomatic cases are really common, particularly for the whole home testing, and that's both for staff and residents. We know that people can get COVID-19 a second time, and they're often asymptomatic the second time. If somebody tests positive, then we treat it as a case. If they're asymptomatic, then instead of taking the isolation period from the day of symptoms occurring, we take them from the day the test was taken. And it's important to use the day the test is taken and not the day the result occurs. And if somebody tests positive for a second time, then it's a case, and we treat it as a case just as we would if it was the first time, so long as it's more than 6 weeks from that first positive result. Okay. That's everything I'd wanted to present today. If there are any questions when this plays out to you, I'm more than happy to answer those. If you can put those in the chat, then I'd be very happy to cover those off. Thanks very much.
All right. Hello, my name's Karen Davis. I'm a registered home manager in Manchester. I manage an 87-bedded care home with units over 3 floors, and probably 70% of our residents are currently living with dementia. I'm here to talk to you today about living with dementia and managing and cohorting residents who are actively mobile. The Department of Health are making some recommendations around cohorting residents living with dementia and suspected or testing positive. So it suggests that residents who are suspected of having COVID-19 should only be cohorted with other residents with suspected COVID-19. The practicalities of that are, as you are aware, very, very difficult. It will absolutely depend on your environment. It will depend on your community. It will depend on your ability to manage people who are resistive to being cohorted or restricted in their movements. My advice would be that you work with what you've got, but you absolutely involve your public health team, your GP, your mental health team, and your CPNs. As we know, you can't isolate anybody living with dementia for probably more than an hour without it having an impact on their well-being. So we understand that although the advice is that this is what we should do, they should only be cohorted. It's not always practical to do that. So in my experience, what we tended to do was we developed areas within the home behind fire doors. It meant moving some residents between places from existing bedrooms. It meant developing spaces from empty bedrooms into communal spaces for residents. So we gave up bedrooms for periods of time. We developed sitting room spaces for residents out of bedrooms. We worked behind closed fire doors where they weren't closed before. But we actively involved relatives, residents, the community mental health team, the geriatricians and the GPs in managing that process, because you can't do that on your own. You need to potentially look at developing different ways of working with those individuals for that short period of time that they do need some isolation. So residents do need the support. You have to work differently while you're working. It's not long term. You have to work differently for that short period of time, for that 2 weeks that those people are going to be in isolation. We developed a cohorted area of 5 beds that we behind a fire door, so we could we created a community space for those residents should we need to. We also used things like alert stickers so that we could alert staff to who was shielding and who was suspected. Why are we going backwards? I'll start again. Residents living with dementia can be walking with purpose, and they can be very mobile and very active. Again, it depends on the environment that you've got. Don't try and do this by yourself. You absolutely need to use your partners to manage that care plan for that individual for that period of time that they need to be in isolation. And it is only for 14 days. It feels like a long time, but you can do this with modifying the way that you work. Things like staggering meal times. We didn't isolate our residents in bedrooms because it just wasn't practical to do that. So what we did was things like meal times. We staggered meal times. So instead of having set breakfast times, a lunch and evening meal, we staggered meal times so that we had generally 2 to 3 sittings, so we could reduce the numbers of people using the space in one time. We had less people sitting in dining room tables. And again, we used our other communal spaces to be able to develop those services. Empty bedrooms became lounges and became dining spaces for residents for periods of time when we were in the acute stages of the outbreak. We didn't keep people in rooms. What we did do with people that were actively suspected or positive and were mobile, we increased things like resident hand washing. We increased high spot areas cleaning. So we sort of developed a system of shadow cleaning. So if a resident was suspected or positive and they were active and mobile and touching handrails and door handles and chairs and equipment, we had a team of staff following around those residents and shadowing the residents and actively cleaning after them. It did create some additional resource need, but I do believe it had an impact on reducing the amount of infection spread throughout the home, and we kept that to a minimum. We used flash stickers, as I said, to make sure that staff understood who was shielding, who was positive, so we could redirect residents so that they weren't going into residents' rooms that were at more risk and were shielding in particular areas. We had dedicated equipment for residents' use, so when we created the new cohorted spaces, we purchased tablets so that they could communicate with relatives. We had TVs and radios, separate activity programs for those residents, lots of increased observations. the way that we worked around delivering care and infection prevention and cleaning regimes, housekeeping. So anybody was suspected or positive, that room was left till last. So we worked around the environment. So we did those hotspots and high risk areas, classed as red areas, last. Residents who needed care, generally we deliver care as required and on priority and resident need. But the resident who was positive or suspected went to the last on the list so that we could manage the potential doffing and donning risks and prevention and reducing the risk of spreading any illness throughout the home. Increased observations was really, really important. We introduced something quite quickly in doing temperature checks for all residents and all staff twice a day, looking for any indicators of any potential illness as well. The issues around not being able to communicate when somebody's lost their sense of taste or smell, we introduced something called the brown sauce test, where we put a small amount of brown sauce on a teaspoon to test whether somebody was able to taste strong tasting things. So that gave us an indicator. If somebody wasn't able to communicate effectively, it gave us another indicator of whether somebody was suffering from not able to taste or smell, and then that would prompt us to be able to get a test for the residents outside of our normal whole home testing once a month. We didn't keep people in rooms, and I don't believe that it increased our infection rate. Some people can do that, and their environment lends themselves to being able to keep people in rooms and keep them active and mobile, and it not impact on their well-being. People living with dementia generally don't take well to that level of isolation. So different levels of activities, lots more one-to-one activities rather than group activities. We did use lots of garden spaces, so we staggered access to gardens so that we kept people very mobile, very active, and stimulated, so that their well-being was enhanced. And as a consequence of that, they were much more settled in their behaviours and potentially less intrusive in other people's spaces, because they were getting the care and the attention that they needed rather than feeling wanting in those areas. So I think that really helped us. I think it's really important that you look at your environment and try and create cohorted spaces, so that if you have a potential positive, that you can isolate that person quite quickly, and think about the practicalities of keypads, fire doors, the use of assistive technologies, beam alarms, pressure alarms, so staff can be alerted to people's movements whilst they're in those spaces or in their bedrooms. In addition to that, if you've got somebody who's living with dementia who's suspected or positive, and they really don't take to living in isolation, and it is having an impact on their health and well-being, you need to talk to your mental health teams about accessing some one-to-one for those individuals, to make sure that the period of time that they're in isolation doesn't have an impact, that doesn't have an impact on their well-being, because that's something that you might not be able to come back from. They may not recover. That might have an impact on their ability to communicate effectively. It might have an impact on their well-being and their mood, an impact on their dementia in the negative, and that we're not looking for that. So my advice would definitely be, use your professionals, use your partners. You're not in this alone as a home manager. I absolutely understand that COVID has taken you away from what you consider to be your normal working life, and it's literally touched on everything that you did before, and it feels like it's an addition to everything that you did before. It is an addition to everything that you did before, but talk to each other, use your support groups, talk to your professionals, take advice from other people, because you're not alone in this. You may feel that you're working in isolation, but there are a lot of people out there that are going through the same thing as you, and have developed skills and expertise and adapted and been creative in their approach to this, and you may be able to use those examples in your own setting. And I think it's really important that you don't feel isolated in this. It is a difficult thing. We are finding new ways of working and being creative in this setting. You don't work in this setting unless you're able to be creative and adaptive, the skills that are required to work in the social care sector are huge and many, and you've just got an additional thing to deal with. And I have every confidence that people can do that, but you can't do that alone. You must work together and not work in isolation. Thank you.
Thank you, Karen. That was great.
You're welcome.
Brilliant. Sorry, I missed you. I read the chat about the stickers about 5 minutes after you'd spoken about them, so my apologies. I missed them, but we can share them. We can share them with people, I think.
The feeling behind that was we didn't want a COVID sticker that was scary. It was really difficult to find a COVID sticker because we wanted to put if somebody's in end of life, we have a little butterfly on the door, alert staff to this person's passing away. So it lets everybody know. And when we had visitors, the visitors understood that you have to be quiet in that area. And what we wanted was stickers that weren't scary. So that's the sticker. The happy sticker is that okay, and I'm shielding. We did scary stickers for the residents because they want to know what the sticker's about. So we taught them and said, because you're at risk, because you've got these conditions, we're putting this on your door so people know that you're shielding. So it's a stop, and that's our COVID. That was the happiest COVID sticker we could find.
Yeah.
Nasty looking viruses. So it was just a small little. It's not huge. It's only a tiny little thing. It's only this big. It was to help people see that somebody was positive, and it was like a hand that said stop. It was an alert to remind staff you're entering this space because there's so many red big crosses. Do not enter. That's not the message we want to be giving our residents or our team, to be honest. So we wanted to develop something that was a little bit more friendly. What I did want to say as well, and maybe somebody else can talk about this, because that we've recognised that there's a thing about poster fatigue, and because we've got so many, Matthew's nodding, there's a poster fatigue issue. People put posters up and then they become blind to the information on the poster. So we've tried to move posters around. So we've got dedicated boards for this and dedicated boards for that, and we've got posters on this door and that door, but people stop seeing them, stop reading them. So we've been working on developing some of our own posters, and I think I've won the prize this month because I developed a sticker that says you can't wish it away, you can wash it away. And it's got people giggling because it's happy, it's positive. I've made a little poster with a little wish thing and a pair of washing hands. So I sent that to the business because what I've been saying is, you've got to understand that people stop seeing the information, they stop reading it, they stop absorbing it. So we're trying to introduce new ways of seeing the same information, the same direction, the same advice, but in a much brighter and engaging way, because people just, you can say, well, you just walked past that poster, didn't? Well, no, I didn't see it, because you just get fed up seeing the same thing. So I think it'd be really good if we could have some competition from the homes about developing really good posters to engage residents and relatives and visitors as well.
It's a really good point, Karen, actually, and there's a lot of what they call behavioural insight work going on at many levels to understand what works and what doesn't. So I'm not massively linked into all that, but I know some people who are, so I'll try and raise that and see if there's any work going on that, because simple things like that.
Something about that. Maybe the homes could get involved and the staff could get involved and residents could get involved in that process.
And I think that's a really good suggestion, and it's great that colleagues will be hearing this conversation that we've just had, because it's really important the way that you have creativity and innovation, and also you keep up the good spirit for both residents and staff using the techniques, the stickers that you've shared. So I'm sure that colleagues listening into the webinar will have other examples of good practice that maybe we could share across with each other. And yes, I think you take the prize this month. Thanks, Karen. Brilliant work. Thank you.
Yeah.
Can I just confirm that everybody can see that before we start?
Yep.
Brilliant, thank you. Okay, my name's Sarah Turner. I'm the Health Protection Lead Nurse for Stockport Council and also the Chair of the Greater Manchester Health Protection Confederation. And just to give you a little bit of an introduction about myself, I've been in infection control for near enough 20 years, with 8 or 9 of those years being within Stepping Hill Hospital at Stockport, and 11 years based within Stockport Council in the Health Protection and Community Infection Control team. So pre-COVID, very similar to Matt really, we manage infections all year round. We do an awful lot of stuff around flu outbreaks and D&V outbreaks in care homes and in other settings. But post-COVID really, we've focused, and during COVID, that's all we've really focused on, has been COVID and how it's impacted across the organisation and across the borough within Stockport, so ranging from schools to care homes to voluntary sector organisations to businesses to outbreaks to contact tracing and so on. So we've really done a very broad range of activities over the last few months with regards to coronavirus. But today I'm going to talk to you about visiting in care homes, and really we need to start thinking about this now across Greater Manchester, because some of us are in the fortunate position where local lockdown restrictions have been lifted, and some of us unfortunately remain within those restrictions. And at the time of broadcast, the guidance around visiting in care homes, not necessarily the process of doing it, but actually who is allowed to visit within those care homes will have changed. So I'm going to cover various topics today. I'm going to talk about them very, very generically. But we're going to be looking at how we can actively social distance in gardens. So I'm going to refer to that as garden visiting from now on. How we can implement some different options, which you may have already implemented, such as window or drive-through visiting. And then how we can safely return to internal visiting or indoor visiting going forward, as and when you are either released from your local lockdown or you're starting that process at the current time. We'll also quickly cover ancillary services such as hairdressers, because these are a vital part of residents' wellbeing, and also other visiting professionals such as district nurses, GPs, community healthcare staff, local authority staff that need to visit the care homes for their quality assurance processes. So I'll start off with garden visiting. And one of the first things that you'll see throughout all of these slides is that there is a very, very clear point to be made around the fact that all visits to care homes have to cease if there are suspected or confirmed cases or an outbreak has been declared. And that's very, very clear within all of the guidance around any type of visiting within care homes, whether it's garden visiting or internal visiting. So what I've done is I've brought together some points that you need to consider for when you're starting to look at instituting any sort of visiting around or within a garden. So we really do need to make sure that we've got a risk assessment of the visitor prior to the visit taking place. And we've circulated guidance from the Directors of Public Health across Greater Manchester, which provides an example risk assessment that you can use to ensure that the visitor that's accessing your premises is as safe as possible. You can also then keep that document for your contact tracing purposes should there be cases of coronavirus identified within the home, potentially when that visitor was on site, or if that individual actually does become a case themselves. It is recommended that within all visiting that those are pre-booked and for a fixed length of time. And again, this is to aid to ensure that we've got good social distancing in place, and that it's not too much of a stress for the resident within the home, but also that we have the capacity from a staffing point of view to manage that. One area of good practices that's been spoken to me about is making sure that the chairs and tables and etc. are pre-placed so that people don't have the opportunity to move those chairs to be closer to their loved one. And that certainly helps, especially if you've got a long table and you sit one person at one end and the resident at the other. And that certainly helps with social distancing. Make sure you've got a staff member available to oversee those visits, again, to make sure that social distancing is maintained, but also to not prevent that close contact between families and their loved ones, but to sort of try and restrict them to the close skin-to-skin contact, which is what they would expect to do when they see their relatives within the home. Make sure that everybody does frequent hand hygiene, your relatives, your residents, your staff members, even if the visits are only taking place within the garden. And staff to maintain their excellent PPE wearing that they've been doing throughout all of this pandemic. And also for visitors to wear the PPE that the home have decided that they need to wear, or a face covering as a minimum. And that should be determined by the home to make that choice. And that might actually impact on the ability of your home to provide that PPE. So really just to be careful about how you decide to ensure the extra safety for your vulnerable residents. And one area of good practice that we've come across within my area is that quite a lot of our care homes have decided to invest in a heated summer house with fixed seating, so that it encourages individuals to maintain that social distancing. The summer house can be used all year round, and it's got adequate ventilation as well. All of the things that are recommended for visiting within care homes. So I'm going to quickly move on now to what we could have as an alternative option. So if you're in the middle of a local lockdown at the moment, you may choose, and the guidance actually says not to have any visiting to the care home. But drive-through visiting and window visiting are very good ways of actually implementing a visiting approach, where your relatives do not come into contact at all with your loved ones or the staff members within the home. There are key things to consider, and some of those are around making sure that your visitors continue to wear PPE or face coverings as a minimum, and that there is adequate cleaning of any windows, that if you do any window visiting, so you don't have relatives using one window and then another relative coming along and using the same window without adequate cleaning in between. Drive-through visiting was very popular at the beginning of the pandemic, and we certainly had cases, and I've seen cases on the television where they've had a very successful drive-through visiting. Probably more appropriate if you've got really decent weather, because then your residents can sit outside and enjoy the sunshine as well. So as we move into winter, it may not be the most appropriate option for your residents moving forward. So as we move on to indoor visiting, again, you'll see at the strap line at the top of this slide that says that all visits have to cease if there are suspected or confirmed cases or an outbreak has been declared within the home. And unfortunately, that has to happen to ensure the safety not only of your residents and your staff, but also the visitors that are wanting to visit. And that has to be clearly communicated in any communication with the visitors, to ensure that they are aware that this could actually happen, and it will happen for a minimum of 28 days, especially if the outbreak has been declared. And at that point, you will have to revert back to your usual way of visiting, or your usual way of making communications between your relatives and your visitors. So using your tablets, using WhatsApp, using Facebook messaging, all of those things that we're so used to using at the present time. So some things that you need to be thinking about, or the processes that have to be put in place to make sure that indoor visiting is as safe as possible for everybody concerned. And one thing the guidance is very clear about is that the care home risk assessment that's produced by the care home has to be signed off by the Director of Public Health. How that is done within your locality may be very, very different. But within my locality, we've got a very defined process for that to happen. The risk assessments are viewed by not just professionals within health protection, but professionals within adult social care, a review is made of those risk assessments, and then a recommendation is made to the Director of Public Health to sign off or to ask for the care home to undertake some further work on those assessments. It's really, really good practice to have a visitors policy and even a code of conduct, because visitors will need to be aware that there will be differences to the visiting that they are so used to undertaking. And they also need to be aware that if they don't comply with that code of conduct, that the registered manager does have the ability and the responsibility to make sure that the residents within the care home are as safe as possible. So she may ask relatives not to visit because they're not adhering to that code of conduct, and that could be quite difficult for a registered manager. But ultimately, at the end of the day, you have the safety of your residents at the heart of all this. It is also recommended in the guidance that you have a single constant visitor that's pre-booked with a defined length of time. And again, within the guidance, it said for no more than 30 minutes. Now, you might choose to look at that, and we've certainly got one home that has gone down the route of the single constant visitor. They are pre-booking, but because of the distance that relatives are having to travel, that they are looking at extending that length of time from 30 minutes to 45 or maybe even an hour. But I think from an assurance point of view, you need to make sure that you have the right systems in place for that resident and those relatives. And it may be that actually that resident can't tolerate a visit for more than half an hour because they've got dementia, or because they become very tired, or that because they've not been used to that constant visitation, that actually 30 minutes is probably just about enough. But again, you may have to look at the risk assessment and say for certain individuals, because of the distance that they are travelling to visit a loved one, that visitation visit might have to be a little bit longer. You also have to balance the benefit of that visit to the resident against the risk of the visitor introducing infection into the care home. And I think that's a real balance and a real tricky thing to balance out, really. And I think as long as you have the processes in place to ensure that you only have one visitor in the home at once, that you have a defined area for that visit to take place, that staff are wearing the PPE, that you've got the social distancing measures in place, and you've got adequate cleaning and hand hygiene, then those visits should be able to take place, but with the proviso that they could stop at any point depending on any cases, any confirmed cases, or if an outbreak's been declared, or as well if people aren't adhering to the code of conduct. You really do need to prepare your residents prior to those visits started, because they will assume that they can go back to visits pre-COVID, and that may be that may reflect that actually those residents require a lot of hugs, a lot of cuddles, a lot of touching of skin to skin, those sorts of things. And you may have to do a lot of preparation work with those residents, that actually those are the sorts of things that can't happen at the moment, but we will work towards them. And it may be that for some individuals where that contact, that's very, very close contact, is needed, you will have to provide further PPE for those visitors to ensure their safety, but also the safety of your resident. And as with garden visiting, an individual risk assessment, visitor risk assessment, is a must to ensure that they've not been in contact with anybody who's had COVID in the past 14 days, that they've not been told to self-isolate, that they're not that they haven't had any foreign travel and they should be quarantining, and also for contact tracing purposes, so that we can quickly identify the individuals that have been within the home to ensure that they're as safe as possible, and be told to self-isolate where required. So some of the things that we've come up with that can help the risk assessment process along, areas for inclusion, really, and they include What will you as a home manager do in the event of new positives? How will you manage any changes to the visiting arrangements? How will that be communicated to your visitors? Do you have adequate hand hygiene access and sanitising stations? Is there easy access for visitors? We've had some care homes that have opened up doorways to external doorways to dining rooms and such, so that they've had easy access for visitors to enter the premises rather than having to go through the home. What cleaning regimes have you got in place, and what is needed extra over and above what you would normally do? So pre and post visit for that visit to take place, and that's really probably a good reason why you should only be keeping those visits to 30 minutes, because you will need some downtime in between those sessions to make sure that the area is cleaned properly. How will you ensure visitors comply with PPE and face covering requirements? As with the visitor risk assessment, there is on the example that we've provided to care homes via the DPHs, there is a requirement for those individuals to sign that they will comply with those requirements. But how are you going to police that? Do you have a member of staff that will be able to sit in that visit and ensure that everything is done as properly as possible? Is the care home fully engaged with the routine testing process? And I know the majority of you are. And I know that Karen has done a really excellent presentation about how you can actually make that as slick as possible. But it's about how you make sure that you do that on a regular basis, so that you can provide assurance to your residents, to your visitors, and to your staff members that it's done as safely as possible. How can you choose your visiting area? How will visitors access it? And this goes back to what I mentioned earlier about the fact that some care homes have decided not to go with internal visiting at all because they can't provide that service, and they've just gone for a summer house in the garden with heating. Some care homes have got the ability to actually knock down walls and put in a door so that visitors can access a particular room, and that will be the room designated for that process. So how are you going to provide that within your area? Do you have enough staff to support internal visiting? Because you will have to have somebody that will, whose sole responsibility will be to police these visits. Have you developed a visiting policy and a code of conduct and risk assessment in light of COVID? Even though you're maybe not at a point where you can commence internal visiting, this really needs to be done now. Mainly because as areas come out of lockdown, relatives will want to visit, but also as the winter months arrive and you come out of lockdown areas, you will then have a plan in place that's ready to go to your DPH for sign off, rather than it having to go at the very last minute. Have you shared this with your visitors prior to any of the visits taking place? And this is really important, so that they know what's required of them, and that they know that actually visits will cease if they do not abide by the guidance that you provided. And how are you preparing residents for this new style of visiting? It will be very, very different for them, especially, as I've mentioned previously, if they've been used to having lots of hugs or cuddles or lots of visitors attend the home. And how are you planning your visits? Have you introduced a booking system? Some of our homes have introduced an e-booking system, and you can do that very, very easily on Doodle Poll. It's a really free and easy system to use for bookings of any description. And then at least that way you've got an electronic record of who's attended and who's booked in and when. And how will you keep a record of who's visited and their movements within the home? It's very easy to say, if you've got somebody who's accessing the home via an external door because they've got no access through the garden into an external room that's accessed via that garden. But if you've not got that process in place, how are you going to manage that visitor and their movements through the home to where you've designated as a visitor site? So I'm very quickly going to now talk about external ancillary visitors. So these could be your hairdressers, they could be podiatrists, private podiatrists. They could be individuals who would like to come and do hand massages or certain activities that you've got going on within the home. And again, all of those visits would have to cease if there are suspected or confirmed cases, or if an outbreak has been declared. So you need to make it very clear to any ancillary visitor that comes into the home that they must not visit if they or any member of their household has any symptoms, if they've had a positive test within the preceding 14 days, or they've been identified as a contact of a positive case and have to self-isolate for 14 days. You need to make that very, very clear to them. And one of the things that we've instituted across Greater Manchester is that if you do have any ancillary staff, ancillary visitors who are regular visitors to your home providing services, and they are there on the days when you routinely do your staff testing, that they are included in that. If not, then it is recommended that they have a regular weekly test via either the postal service or the drive-through sites. You need to risk assess the rooms that are going to be used, such as salons and treatment rooms, for example, and to make sure that you've got a one-way system, or you've got social distancing in place. You may need salon screens between chairs if you're going to have the hairdresser have two residents at once within the salon, for example. So the hairdressing guidance is really, really useful. We've circulated that previously via the Directors of Public Health to any care home, but also the hairdressing guidance or the activity guidance that is available from the government websites for the different services, and the reinstitution of those different services within the wider community can actually be interpreted for care homes. Obviously, all your ancillary visitors have to adhere to the hand hygiene, PPE and social distancing within the home, and you have to have a specific cleaning schedule for the rooms being used. And each of those individuals would have to pre-book, as everybody else would need to do, to come into the premises, and also make sure that they complete that risk assessment as you're asking other visitors to do. If, for example, if it's a hairdresser, it may be that you request your hairdresser to use disposable or the residents' own equipment, such as hairbrushes and rollers, for their individual residents, rather than having shared items. And finally, we're just going to talk about visiting professionals. Obviously, a lot of GP visits have been being done virtually. A lot of CQC inspections, for example, have been done virtually. I know continuing healthcare teams have been doing virtual visits along with social workers, but there will be an increasing requirement for those individuals to gain access to the premises, to the homes, to ensure that their mandatory requirements, their statutory requirements are being met. For example, environmental health officers and food inspection visits. Again, these would need to be pre-booked by the professional with a registered manager. Very, very similar process that you would have with normal visitors. We would definitely not be recommending any ad hoc visits at all, and we would be recommending that these are all pre-booked with the registered manager. Those professionals need to complete the risk assessment prior to the visit. This could include confirming the date and result of their last test. And most local authorities now and CCG staff have got a plan in place for regular testing of these professionals to ensure that they are as safe as possible before they enter your premises. It's also vital that you keep those requirements, those risk assessments, so that you've got a track and trace system in place for those members of staff. PPE will have to be worn by those individuals, and again, that's the registered manager can determine the appropriateness of which PPE needs to be worn and when. So, for example, if somebody's going into an individual resident's room, they will have to wear full PPE, but if they're going into a communal area, they may only have to wear a face mask. Obviously, hand hygiene and social distancing has to be maintained at all times. It's recommended and good practice that they only visit one care home per day rather than going to multiple homes. And it may be that actually they do another professional's, or they seek questions to other professionals' requirements whilst they're on their visit. So you might find that somebody who is a continuing healthcare member of staff We'll also be asking social work questions, and that will help to reduce the number of visitors that care homes are expecting from professionals. We are recommending that professionals avoid the use of public transport and car sharing where possible, but if they do have to use those, that they comply with the requirements of those that public transport, and if they're car sharing, that they actually sit in a car with the windows wound down so we've got adequate ventilation, and that they wear a face covering. That those professionals follow the guidelines that are provided by the care home, and that's really the priority here, because if they veer off from that, actually they could potentially be putting the residents and the staff members within that care home at risk. So that's the end of my presentation. I hope you've enjoyed that. Thank you for listening, and if you've got any questions, we'll be able to take them in the chat. Thanks very much. Bye.
So we're really pleased to have a video shared with us from the team at the Broughton's Care Home in Salford. Amanda Collins, who's the care home manager, couldn't join us today. But this is a really good example of good practice that we wanted to share with you, and also to ask you as the audience in your own practice, if you've got examples of good practice to share back across the whole of Greater Manchester. So if you've got videos, if you've got stickers or any other good practice, please do share. So this video that's shared from the team at the Broughtons is about donning and doffing of personal protective equipment, and they'll run through the process with us. So I'll share that video with you now, and I'll hopefully you'll be able to both see and hear the video, which I will start now.
Wash hands. Mask. Wash hands. Gloves.
You're actually wrong. Should I put your goggles on?
No, we're going to goggles. Right, now we'll take them off. Yeah, gloves. Down, wash hands. Apron from the back. Down, down. Put, fold in half. Throw in the bin. Wash hands. That's off. Throw in the bin. Wash hands. Yeah?
Hooray! Well done.
So excellent, that's great. But what the video also demonstrates is the role of the COVID coordinator. So we know that some care homes are practicing this every day, where the COVID coordinator at the start of the shift is observing people as they put on and take off their personal protective equipment. So we really do thank the team at the Broughtons, but also all of the COVID coordinators across all care homes, because we know that you are really looking out for your staff and for your residents. So thank you to everyone, teams, and COVID coordinators and all the public health teams, all of the people who are working tirelessly behind the scenes to make sure that people are safe in the care homes, but also to make sure that we are producing this webinar and that we're able to share the good practice. Thank you. Thank you, everyone. I hope you've enjoyed the webinar, and I'll just hand over to Mark, who wants to say a few words on behalf of the DASs.
Yes, thank you, Muna. Just mindful, really, we've got 10 GM authorities with a number of homes in each of those authorities. And I wanted sort of to give a personal thank you really to everybody who works in the care sector, and particularly those people who work in the care home sector and nursing care sector, for the fantastic job that you've done throughout this pandemic. It's been truly inspiring and amazing, and I hope what we've tried to do as Director of Adult Social Services during this time is do whatever we possibly can and could do to ensure you feel supported in the provision of care to all of Greater Manchester residents, and particularly from a point of view of myself, obviously being the Dassin Stockport residents. So really, it was nothing but to acknowledge the tremendous job you've carried out during this time and continue to carry out, and to give you that commitment that, you know, our hands aren't always as free as we would like, but we've looked to do whatever we possibly can during the pandemic to make sure you all feel part of a wider family of support in the you know, the fantastic job you do supporting the most vulnerable residents of Greater Manchester in your care homes. So I wasn't going to probably expand beyond that. You know, the guys that you've had on the webinar, the recorded webinar, and others that are here today are the experts. I'm by no means the expert, but what we'll continue to do across Greater Manchester is give you whatever we can by way of support. And thankfully, we finally, as of last week, got information to say that the infection protection control monies will continue up to March 2021. There was also announcements on free PPE being available until March 2021. And that's in the Adult Social Care Winter Plan that has now been issued by central government. So we will see continued funding to enable us to make sure that we implement infection protection control procedures in care homes and the wider care sector throughout the remainder of this financial year. So I'll stop short there just in case there are others who want to comment at the end of this. But sincere thanks to everybody for everything you've done during this unprecedented pandemic. Thank you, Muna.
Thanks, Mark. And we know, of course, we're heading into winter where we've got additional challenges around flu and winter preparedness, and we'll sort of keep that conversation going. I just think that we may have had some technical difficulty with the chat function. So at least I couldn't see any chat coming through and I wasn't able to put in any. So if you've still got any questions that have sort of arisen for you during the latter two conversations, particularly, for example, the presentation on visiting or on the PPE donning and doffing, please feel free to share them with us by email afterwards if you don't get the chance to cover them off from here and now. We've got about 10 minutes left. So I'm just wondering if I can see, Mark, you've got your hand up, please. Yes, please do come in.
Sorry, I said I wouldn't say any more, but I think just mindful really on the back of what Muni's just said in terms of flu season and flu vaccination. I'd make an absolute plea that, you know, I think again we want to support care homes as much as possible. I know locally in Stockport what we're suggesting is that I think general practice will vaccinate residents, but we're making a plea to try and get your staff groups vaccinated by way of linkage with the with pharmacy and inviting a pharmacist into the care homes to give the staff group their vaccines, so we're getting as much coverage as we possibly can for this season. And again, if there's anything more we can do in relation to ensuring that that message really is as widespread and hits home as much as possible, then please let us know and we'll do that. So it was just to follow up on Muna's point. It really is important this year particularly, if not in previous years, to ensure that we get as much coverage as possible on the flu vaccination.
So normally we would have been answering some of the questions that were posed in the chat function, but of course we don't have that at the moment. So I'm just wondering if Karen or Sarah or Janine or colleagues who've been behind the scenes in preparing this webinar, you had any additional points that you wanted to say? And we will definitely take the questions away if you can email those to us, because the chat function doesn't seem to be working. So I can see Sarah. Would you like to come in, Sarah?
Yeah, just to say thank you very much for everybody's attendance today. It's really, really great that you all managed to spare a couple of hours of your time to listen to this webinar. And again, I reiterate what Mark has said really regarding the flu vaccine. It really is crucial this year that staff get the vaccine to protect themselves and their family and their loved one, their residents from the flu. It is really, really crucial this year. So really reiterate that Mark has said. And if you've got any questions, again, either put them in the chat when it's re-established, or please just email them to Mark and we can answer them from that. Thanks a lot.
Thank you. Thanks, Sarah. We've got Janine.
Yeah, and from myself again, thank you. There were 117 people that stayed for the 2 hours of this webinar, and I appreciate how precious your time is. So clearly, I hope you found it valuable. By virtue of you sticking with it, I feel you probably have found it valuable. Please email Mark about anything by way of future webinars. We will respond to the need. And then finally, a really special thanks to Mark Brown, who actually had a full head of hair before he started putting this webinar together. He looked like Goldilocks. However, you can see the effect that it's had on him. But yeah, a real thank you to Mark, and I look forward to the next one.
Pleasure.
Yeah,
My email address
just
is in the
sorry,
chat.
Mark, before you come in, sorry, I don't want to talk over you, but I put my hand back up because I absolutely second that. Thanks for all your efforts in pulling this together. I hope not just beyond today, but into future conversations as well, we'll find this really, really helpful on an ongoing basis. So fantastic piece of work, and thanks for pulling it together, Mark.
Pleasure. That was useful. My email address is in the chat there, just to mention. I will circulate. I'll drop an email through to everybody as well. And appreciate, I think there's some people who forwarded the invitation to colleagues, so I might not have their address. So if you could forward my email to them, that'd be great. Thanks.
Thank you. So I think we've got 3 asks from the audience today. If you've got any questions that we weren't able to take today, please email them in. If you've got any comments or suggestions for a future webinar, which we can pull together very quickly to respond to what you're requesting of us, we can do that. And then if you've got any good practice that you'd like to share, we can also sort of showcase that in the coming webinar as well. So it's been great that you've all managed to join us, and we'll probably leave it here for now until the next webinar, until we're able to send across the whole recording from today and also some of the responses to the questions that will be asked to us. Thank you very much for your time. Great stuff. Take care all.
Thanks, everybody. Bye now.